All right, we're just going to go ahead and get started with some basic um, uh, introductions. And I want to, first of all, introduce my two co-hosts. I've got Dr. Vincent Domingo, and I've got Lance Liberty here to talk to us today. And between the three of us, we're gonna try to give you a really good overview of the amniotic allograft injections and the potential for not only the income potential, but really what it can do for your practice and for your patients. And so over the last few months, I have gotten literally hundreds and hundreds of calls from doctors all over the United States wanting to implement this program, wanting to implement the allograft injections. I'm getting a lot of calls from doctors who are saying, well, I heard this and I heard that. And so really what I wanted to do with this call today, or this webinar today, is try to create the reality of what this is. What are these injections? How do they benefit the patients? How do we bill for them, if we can bill for them, and so on and so forth. And so between the three of us, we're going to try to help you all sort through this and decide if this is something that you would want to take on in your practices, in your regenerative medicine practices. And so I'm just going to go ahead and get started. Let me see if I can get my screen to move. Yes, I can. So we have myself, and I am, again, my name is Lisa Majeski. I'm the owner of Gold Star Medical Business Services. We are a full-service medical billing and practice consulting company. We do billing, staff training for doctors, credentialing, insurance verifications, really all the nasty work that you don't want to do in your office anymore. You can turn over to us, and we've got people who will help you do that. And so definitely, if you ever want to find out more about our company, I'm more than happy to do a call with you. At the end of our presentation, I'll have our contact information up so you can contact us with any questions you have. I also have here with me Lance Liberty. Lance, do you want to tell everybody a little bit about yourself and who you are and what you do and how you're involved in the regenerative medicine field?
That'd be great, Lisa. Thank you very much. I appreciate the introduction. So I actually got into the regenerative medicine field first as a patient. I had suffered a high school football injury over 2 decades ago and had a surgical repair done. That repair eventually failed, and it was through first injection of hyaluronic acid and later use of regenerative medicine products that I was able to avoid the knee replacement surgery that I was supposed to receive and regain normal function. I actually wound up co-founding a clinic with a doctor who injected my knee. I convinced him to open up a practice, and that's how I got into practice ownership. My original role was marketing and driving new patient flow, because that's my historical background. And over the years, as you know from running a practice, you've got to learn every aspect of it. So I got self-taught on the billing and compliance. I wound up going to all the CE courses and fellowship trainings that our clinical staff did and getting administrative fellowships at those places. So I kind of slowly oriented myself to the entire medical business and built a really successful practice there in New Jersey, and eventually started licensing the business model that we had developed and the operational system that we had created to practices around the country. We've now trained and certified over 200 clinics in 38 states in our advanced arthritis relief protocol. And 5 years ago, we developed our own line of platelet-rich plasma harvesting kits, which are FDA 510K cleared. And we obviously co-treat with a lot of allograft products, some autologous products. When patients present in different stages of their degenerative diseases, whether it's osteoarthritis or other musculoskeletal disorders, we have to go to that toolbox and pick out the appropriate tools to work with them. Amniotic fluid has been part of that toolbox for a long time, but with the recent development over the past few years of some of those products being registered and assigned HCPCS codes, we've had the ability to use those with patients that might be on fixed income or have limited ability to pay for out-of-pocket services, with some federally funded health plans and major commercial carriers as well. So I'm here tonight to kind of to share with you what we've experienced firsthand in implementing these products. And I'm going to speak mostly to the documentation side of things and identifying patients that might be good candidates, how to work up those cases, on paper to create the basis that at least this company will be able to secure your prior authorization for with your commercial insurances. And then Dr. Domingo is joining us here tonight to share some of his clinical perspective in operating one of these practices and directly treating some of these regenerative medicine cases. So now I'd like to hand it off to you, Dr. Domingo, if you'd like to share a few words.
Yes, thank you, Lance. I'm Dr. Domingo. My background is actually in chiropractic, board specialty in orthopedics. I've had the pleasure of working with Lance and regenerative medicine for, I think, about the last 7 years. I started off as a client, and now I work with the IPS team and help with training and helping other doctors integrate these procedures and protocols properly into their practice. I've had a lot of success over the last 2 years in some of my newer offices where I have partnerships and help with operations. And we've helped to date a lot of patients get better. I think about 95% of our patients do get better, and we do treat a lot of orthopedic conditions. So it's been a pleasure to take this regenerative medicine, this new paradigm in healthcare, and improve patients' lives.
Great, thank you so much for that. And we're going to go ahead and get started with you, Dr. Domingo. I did get a question. By the way, in your Zoom menu, there is a Q&A box, and if throughout the presentation you have questions that come up that you'd like to, we're gonna try to have some time at the end of the presentation to answer questions. And so if you want to type those questions in, we will be happy to entertain those questions. It could be that when you ask a question that it will be answered during this presentation, but if it's not, then we'd love to be able to answer those questions for you. So feel free to use the Q&A. One question that we already have is, will this be recorded and added to the website? The answer is yes. This is being recorded, and I will be converting the recording at the end of the presentation, and we'll be posting it on the Gold Star Medical website. And so, and I will be happy to send anybody a link to that that would like that for sharing purposes. So, you know, what we're here today to do is to just give you information, give you data that you can take and to make informed decisions about whether this is a type of treatment or a type of therapy that you would want to have in your practice. So, Dr. Domingo, I'm just going to close my Q&A box. So let's, would you speak a little bit to the actual amniotic fluid product and process of what this is and how it works to help patients heal?
So the amniotic fluid, just as the amnion, the innermost layer of the placenta, protects the fetus during development, it's also providing the same protection to injured or traumatized tissue. Amniotic fluid has its components. It has its collagen substrates, growth factors, amino acids, carbohydrates, cytokines, hyaluronic acid, fibroblasts, epithelial cells, and other cells. Its activity, it's multipotent amniotic cells, and they've been proven to be able to differentiate or change into adipose tissue, bone, muscle, skin, nerve, and even liver cells. So amniotic fluid has been a perfect match for synovial fluid in joints, and it exhibits anti-scarring, anti-adhesion, anti-inflammatory properties. We've had a lot of experience working with this in my office. Again, my background is mainly in orthopedics, so we do a lot with knees to use amniotic fluid to help with tissue healing, cartilage, meniscal tears, in adjunct to other therapies that we provide. So the membrane is rich with basic components necessary for tissue regeneration, providing an antimicrobial environment and an anti-inflammatory characteristic with anti-adhesions and anti-fibrotic capabilities. To remove the risk of graft-host reactions, the chorion, which has been known to contain maternal antigens, has been removed, and this maximizes the potential benefits of amniotic membrane in a variety of medical and surgical specialties. What we're trying to do is basically fill, cover, and protect a tissue void or defect. Additionally, the nature of the amniotic membrane has been shown in multiple research papers and applications. A lot of people are using this in ophthalmology, again, for me, orthopedics, dentistry, and wound care.
And it's my understanding that for, it has been approved very widely for wound care for many, many years in the forms of tissue grafts. But this is a little bit different. What we're talking about today are actually injectables for a very specific purpose that I'll let Lance get into. This has been around for a while, but the applications that they're now considering for payment are being broadened. And so tell us about how that tissue regeneration works, Dr. Vincent.
So the tissue regeneration is helped by the mix of electrolytes, its growth factors, carbohydrates, lipids, amino acids, enzymes, and hormones. These components are working together at the site of injury to help with tissue repair. So basically, it's a nice cocktail of healing factors and components that will basically migrate, infiltrate, proliferate, and differentiate to culminate in an inflammatory response and the formation of new tissue.
That's just amazing. I'm just going to say, I'm not a doctor. I come at this from the other side of things, just as a layperson. And, for me, when I hear something like this, I personally get really excited. And I can imagine, I would love to hear from you. How do your patients react to this when you tell them that there's this type of therapy available?
Most patients are actually really excited. A lot of patients, for me especially, they come to my office to avoid medications, surgeries, and they want some sort of natural healing. And since this is basically from natural cells, they enjoy the fact that there's no real side effects, and the benefits outweigh the risks of having to take chronic meds or risk going through surgery.
Yeah, just amazing. What about the quality of these products? One of the things that I get a little bit about is they're worried about, the quality of the harvesting of the products and the safety of these products. So can you talk a little bit about that?
So these products are typically screened intensely, especially with the litigation and the scrutiny of stem cells. A lot of people are looking at this, so we have to be very sure that the products follow certain guidelines. Those guidelines include going through the initial donation and screening the patient. So they're going through a whole medical, social history, sexual exam, physical exam. They're screened for HIV and hepatitis, make sure they're free of any disease, free of any malignancy, and free of infection, where they go through a full serology test and screen the patient up and down. As far as the donation itself, these are from live cesarean sections. These are donations that are basically screened through a medical director. They're evaluated prenatally, including cultural and serological testing prior to delivery. Recovery is performed by trained technicians using aseptic technique, so no harm is done or brought to the parent or the child, and they still have the option of storing the cord blood. All the processing is performed in an aseptic environment in the American Association of Tissue Banks in an accredited facility. All processing is performed following the guidelines of both the FDA and the American Tissue Bank. In addition to serologies, culturing is performed at every step. And even after the products are finally processed, they're retested post-processing to demonstrate the absence of any bacterial or fungal pathogens.
So what you're saying is about the culturing is that throughout the process, they're going to test it to see if any cultures of maybe disease are growing within the cells themselves. Is that correct?
Yes.
Okay, awesome.
So again, as far as my background, with the chiropractic philosophy and my beliefs, or which are to prevent or to help patients and prevent the need for unnecessary medication and surgeries, this has been a very good process for a lot of our patients and very successful, to the point that I could honestly say, with the combination of therapies that we use, and this as one of our avenues of care, 95% of our patients have been able to avoid medication and help with their chronic pain and injuries and avoid surgeries. One of my favorite patients was Vanessa, and she wrote a nice testimonial for us. She had a total knee replacement and wanted to avoid surgery on the left knee. She just didn't have the experience. And after her amniotic injection, when she walked up the stairs that evening, her results were just that immediate, that she didn't have any pain in that knee, she couldn't believe there wasn't any pain, and she didn't even have to be ambulatory and have to hold herself up using the railing just to get upstairs anymore.
That's just amazing. I'm sure she was thinking, you know, gosh, I should have done this on the right knee before I ended up having to have that total knee replacement surgery. And that's really what we're wanting to do, you know, with these patients that are, you know, looking down the barrel of having to have their knees replaced. You know, and instead having this amazing therapy that they can undergo in order to completely avoid and having that pain gone immediately. I mean, it's not like you don't even have post-op complications or post-op, you know, pain or I mean, it's just unbelievable. So just super, super exciting. For me as a layperson, it's very exciting. So Dr. Vincent, thank you so much for talking on that. Now, Lance, you know, you're the guy that really has this innate understanding of these products and the differences between these products. And so if you would talk to that would be awesome. You know, if you can talk a little bit about, you know, about what these different types of products are, the properties and so on and so forth.
Thanks, Lisa. I appreciate it. And we do have a great deal of experience of the entire gamut of regenerative medicine products and tools, because as we've been facing these cases clinically, you never want to be the last stop on the patient's progress before surgery, where you say there is no other option, there's nothing else we can do. We want to exhaust those options fully and make sure that on those few cases that maybe unfortunately don't get positive results from injectable medications or non-surgical alternatives, that they at least have the peace of mind that they've exhausted all those options before going under the knife. And part of this is going to be about understanding where these products come from and what they do. So there's really two main categories of regenerative medicine. There's autologous treatments, which is a Greek word, means from the body. And there's allogenic products, which are transplants or allografts that come from someone else, either a direct donor or a tissue bank or an orthobiologic product that maybe has been manufactured in the laboratory setting. So these are your two main categories of products. And when you're looking at the autologous products that come from the patient, there are some considerations as to candidacy. The older a patient is, the lower the concentration of their mesenchymal stem cells in their bone marrow. The restrictions of FDA and their reduction of what's called minimal manipulation or homologous use guidelines have made things like adipose tissue harvesting more difficult or almost unable to be done in the United States, because you're not allowed to add anything to that or manipulate that fat tissue in any way. So you really can't unlock those adipose stem cells like we used to be able to do years ago from patients. Risk factors for the harvest. If you've got patients that are smokers, that are on blood thinners, that have previous cerebrovascular events or previous cardiac events, that can make an autologous harvest risky for that patient. And then also understanding the physiology of the mesenchymal stem cells or even the growth factors and other regenerative products themselves is what they do. So when you're dealing with stem cells, the first aspect of them is called homing. They are attracted to apoptosis, to cell death, to inflammation. So if you do an autologous harvest and maybe you're doing a bone marrow biopsy, usually it's done of the long bone of the leg or the iliac crest of the hip, that cannula that's taking that sample is creating an injury, creating inflammation, creating cell death. So some of those cells that you harvest from an autologous recovery may actually wind up going to heal the site of the harvest itself, as opposed to being focused on the injury that we're trying to treat. So then when we look at these allogenic products, these allografts, we're getting very young because these are from placental tissue, amniotic fluid, Wharton's jelly of the umbilical cord, different aspects. You're getting basically young 9-month-old, usually cellular material at its peak of potency and ability and also concentration. So when you've got an older patient or you've got a patient that's immunocompromised or a patient that has other risk factors that would reduce the viability of their own stem cells or their own growth factors, going to this transplant tissue provides a better quality. It also creates less risk. You're not having to worry about the risk factors of the harvest. It's a faster, simpler procedure. It can also be done in an outpatient setting. You know, when you're doing these autologous procedures and bone marrow biopsies, those also usually have to be done in a surgical setting, in a sterile setting. You can use a lot of these allogenic products outpatient in a primary care office, in a pain management facility, in an integrated medicine facility. So it's going to give you more tools accessible in your toolbox if you don't have access to that type of a sterile surgical facility, in addition to potentially being more effective and less risky. And these products are available both as tissue grafts and injectables. So when you come across these allograft products, you basically have your dehydrated products that are shelf stable, usually patches, and those are typically used for wounds. When we talk about the brand of products that we will tonight from the tissue bank we work with, ProMatrix would be the patch version. So if you're treating a patient that has a topical wound, a burn, loss of tissue that's external, that patch might be applied. But for the primary utilization that we at least do in our scope with musculoskeletal disorders is the injectable version, where you're dealing with the amniotic fluid and in some instances also the amniotic membrane. Now, up until just a few years ago, all of these products were not covered by insurance. They were all self-pay elective procedures or cash procedures, as you might call them. But almost 3 years ago, the FDA released a large document. It was a letter of industry guidance, and it was advice on homologous use and minimal manipulation guidelines for the human tissue industry. And basically it said the tissues you take from the body have to be used in a similar like fashion when they're put into another body, when you're dealing with these allograft products. And they gave a 3-year window for all these tissue banks and companies to basically come into compliance with these guidelines. And that 3-year deadline is going to be this November, although there's some chatter it might get pushed back because of COVID-19 and so forth, like so many other things we're encountering. But these companies then at that point said, okay, we're going to be more heavily regulated. Some companies chose to register these products, to start applications, trials called INDs for new drug approvals. And it led to some of these products being registered with the FDA and cleared. And after that happened, having the ability to submit their products to Noridian for professional data and coding analysis and getting assigned billable codes. These products are assigned HCPCS codes, which are Healthcare Common Procedural Coding System numbers. And these are used typically to supply, to describe products, medications, injectables, and are also used for any new things that are created and brought to market in between the versions of current procedural terminology that are published by the American Medical Association. So that's where these fall into this HCPCS category. Tonight, we're going to review a product that's had the most favorable adjudication and coverage by most health plans that we've encountered. And it's just one of many. So one other thing I do want to clear up is that we'll use the term stem cell a lot, maybe during this presentation or common conversation, but these amniotic products right now that we're using actually don't contain any live mesenchymal stem cells. Part of the registration and clearance process with the FDA, these products had to be sterile. So in order to be sterile, they had to be irradiated. And when they're irradiated, that will actually kill the mesenchymal stem cells. That's why if you do injections of stem cells and use fluoroscopy, it's very important not to run the fluoro while you're injecting the stem cell because you might damage or destroy it. So do be careful when you're talking about this to your patients and when you're promoting it, when you're documenting it. What we're doing here is a human tissue transplant, an allograft procedure, not a stem cell procedure. And when you're talking about stem cells, there's actually more than one type. There's hematopoietic stem cells that are derived from cord blood, and then there's mesenchymal stem cells that are typically derived from the protein matrix, usually the Wharton's jelly of the umbilical cord. So you've got certain products that are approved, certain products are not approved, certain products that are approved for certain uses. And then I also want to point out that stem cells are not new. Stem cells have been used as transplants, human tissue transplants, for over 4 decades. I'm sure you're familiar with patients that might have leukemia or different type of cancers of the bone or of the blood, where they get a bone marrow transplant. That's a stem cell transplant. So the human race has been using stem cell transplants for going on almost 50 years now. It's just that our ability to process, harvest, and store these cells and use them more effectively has really expanded a lot in the past, really 10 years, to be completely honest with you. The technology is really advanced. So examples of some of these regenerative medicine products would be mesenchymal stem cells. They're the holy grail, if you will. These are the most powerful, potent, pluripotent, actually, cells that can be worked with. And they can either be harvested from the patient autologously, such as adipose fat derived or bone marrow derived, or they can be taken from allografts. Typically, again, the Wharton's jelly, the protein matrix of the umbilical cord. It's a great source for it. You might also see products that are cord blood derived that requires filtration and concentration. Personally, I'm a little partial to the Wharton's jelly products because you don't have to worry about inclusions of any red blood cells or lysed cells that could create not a rejection, but an immune response in the patient. So if you've ever seen a consent form where it says, if you have flu-like symptoms, you know, that's probably a cord blood derived product, because a Wharton's jelly derived product, it's not gonna be able to produce a flu-like symptom because there's no genetic material that's gonna cause your body to have an immune response to it. Then when you look at the amniotic fluid allografts, while these don't contain live mesenchymal stem cells, they do contain rich in growth factors, rich in cytokines, rich in what's called cellular scaffolding. So hyaluronic acid, heavy chain hyaluronic acid, collagen, type 4 collagen, fibronectin, elastin, essentially the building blocks of soft tissue. So mesenchymal stem cells can regenerate hard tissues or soft tissues, neural tissues, etc. Amniotic products can really only regenerate soft tissues. So if you've got a loss of bone, like a reduction of the humeral head in an osteoarthritis shoulder case, an amniotic fluid might not be the best indication. But if you've got a rotator cuff tear, if you've got a previous meniscectomy where part of the meniscus has been removed, if you've got a loss of soft tissue, that's really where these amniotic products shine and are meant for. And then you've got platelet-rich plasma, which can be covered by some insurances under the code 0232T. That is a temporary code. It's mostly recognized right now by workmen's compensation, federal employees under OWCP or Department of Labor contracts for workplace injuries, auto accident coverage with PIP and different auto carrier insurers. And then sometimes you'll also see coverage with captive health plans, where you've got a large employer that has a privately funded health plan that's administered by one of the big brands. They will oftentimes cover this. We've got a lot of clients in Atlanta, and we've seen Delta, which has a big hub in Atlanta, cover PRP for injection into their employees. So if you do treat any workplace injuries or self-insured patients or federally employed individuals, you may actually be able to even receive reimbursement for PRP. And Lisa and Gold Star Medical Billing can help you verify those benefits, gain the prior authorizations, and see if that coverage might be there. So that's a big picture of kind of your 3 main categories of regenerative medicine products. So what do these products consist of? We covered that a little bit on the last slide, but speaking specifically to these amniotic membrane and fluid products, while they don't contain live mesenchymal stem cells, they do contain growth factors, cytokines, collagen, fibrin, type 4 collagen, elastin, hyaluronic acid, and messenger RNA. If you've done research into regenerative medicine or you're a regenerative medicine provider, you might have heard the term exosome used before, or what is also sometimes called a secretome. So this is RNA and microRNA that's expressed from mesenchymal stem cells. And the analogy I like to use when explaining this to patients is, if you've ever seen an anatomical drawing of the body, and it's got the layers that you can go over, the muscles, the blood vessels, the nerve endings, you'll see all those blue nerve endings. They don't go all the way to the end of every point in your body, right? So if you were in school and you had to pass a note to somebody to get it to the next person, it was handed off, right? So these cells will actually hand that signal from the nervous system over to other cells in the area by excreting these microRNA and RNA proteins, which will exit the cell, get encapsulated in a lipid capsule, bond with the outside lipid capsule in the next cell, put that message in essentially through the RNA, and then this process repeats. So it's called cellular signaling It can also be called cellular recruitment or the paracrine response. A big part of regenerative medicine is how the body responds to what we put into it, because we're putting a small amount of concentrated product in there. And I oftentimes use the analogy of throwing a bucket of water into a lake. But if that creates a ripple effect, it can affect the whole body of water, right? So that's what we're trying to do with regenerative medicine products. It's not necessarily what you're injecting, but what happens after you inject it internally, the recruitment. And these amniotic tissues can create that signaling and create that recruitment to help that multipotent process take place where there's differentiation of new tissue, particularly structural tissue.
Awesome.
So indicated uses. One of the most common questions I get is what diagnoses codes are covered for these products? And the answer is all of them and none of them, because it's not the diagnoses code that builds your medical necessity for this. It's the physical and objective examination of the patient. When we go back to that industry guidance letter that FDA published, homologous use was the first part of it. The cellular tissue or allograft must be used in the patient in the same way it would function in the donor. So how does amniotic fluid and placental membrane function? It's a cushioning and protective coating. So when you look at how you can use this, it has to be used in an application where it's providing that cushioning and protective coating, and specifically to fill, cover, or protect a void or defect. So let's talk about a knee real quick. How would you show that you needed this in a knee? Well, if you had a meniscal tear and the patient had an x-ray and there was loss of joint space, and you did a physical examination and you did a McMurray's test or an Apley's compression test and they had positive findings, there's likely going to be meniscal involvement from that McMurray's and that Apley's compression test. You add that to the radiology with loss of joint space, there's likely a loss of tissue. You have a subjective examination from your patient, which we'll get into with Dr. Domingo again in a little bit, talking about the KOOS, the knee osteoarthritis outcome study. So you've got subjective, patient's complaints, you've got objective radiology and your manual orthopedic testing. And then a third component of it is having to actually try and fail some things, which we'll get to in a couple of slides. But based on this definition, what type of things can you use it for? Well, the most common things that we're using it for is loss of cartilage. Meniscal tears, slap tears, those are really clear indications. Also, peripheral neuropathy has been a pretty good indication for us because in peripheral neuropathy, whether you have an overactive nerve or an underactive nerve, the reason it's malfunctioning is because the myelin sheath has been damaged or destroyed, usually from a lack of oxygenation, which is why you see this in diabetic people that have lymphedema and circulatory issues, or in chemopathic patients where there's been chemical damage of that myelin sheath. So if you do a nerve punch biopsy, which documents we're missing myelin sheath, you add that to the patient's subjective, now you've shown there's a tissue void or a defect. We're going to fill it and provide a protective coating with this amniotic product or placental tissue membrane. So those are very good.
So Lance, just talking about all of these different applications that can be used, from what I have seen anyway, even though there are so many different indicated uses of the amniotic membrane tissue, there's only really a very narrow scope that really can be billed to the insurance company. Isn't that correct? Most of this is just going to be like your typical, when you're doing the regenerative medicine, the stem cell injections, it's going to be a cash service for the most part, but there are indications that the insurance companies may consider it for certain orthopedic applications. Mm-hmm. Isn't that correct?
That is correct. And there's also some criteria, not only criteria from physical examination and documentation, but one of the variables that we found that actually helps us get coverage and favorable adjudication is the economic factors. If this patient has failed these therapies, if they're likely to be on long-term opiates, or if their next step is a surgical intervention, essentially, if you can reduce the risk and the cost to the insurer, especially when you're dealing with commercial insurances, that's something that they're going to look favorably upon. So when we write these letters of medical necessity, of which we'll review some examples later, that's really the narrative we're trying to tell. And while these products do have these billable codes and they are covered, you've got to use them in the right fashion. And also, they're only covered by certain payers. So Medicare and TRICARE will cover these products without prior authorization, but through something called a prepayment review, where they're going to determine whether or not you'll get paid based on the validity of your documentation.
I'm gonna take you over there real quick.
Oh, thank you.
Yeah, let's talk about that.
Yeah, so Medicare and federally funded health plans like TRICARE and VA patients do not require or offer prior authorization. They go through a prepayment review. So you'll submit your letter of medical necessity, you'll submit your exam note, you'll submit your procedure note, and whether or not you get paid is going to be on the content of that documentation. Now, that downside of a prepayment review is you may not get paid. If you're putting in a case that's not really well qualified or built up for it. But the upside is no post-payment recoupment because your chart is being audited. You can only get audited once. It's like double jeopardy. If you get tried for murder and they find you, not guilty, you can go write a book about it like O.J. Simpson did, and there's nothing anyone can do. So the same thing kind of applies to these federally funded health plans. They're looking at it first, then paying you. So with Medicare, particularly, physicians are usually afraid, what if I have to give the money back? What if I have to give the money back? Well, you'll never have to give the money back in these cases because if they pay you, they've already reviewed the chart and done that review. So that's the pro and the con really all wrapped up into one with your federal players. Then you look at your commercial payers. United Healthcare Medicare Advantage plans will typically favorably adjudicate this. Blue Cross Blue Shield has pretty broad coverage and favorable positioning on these products for these indicated uses. You'll get most of, well, a majority, and it depends on your state, other factors, but those payers will typically approve the prior authorization to generalize. Then in this second column, partial payers, these will approve some, deny others, a little more stringent in being willing to provide the prior authorization. And we see that in Humana, and I would say Humana is probably a little nicer and more generous than Aetna. Prior to COVID-19, Aetna was pretty generous. With COVID-19, the bean counters have been hard at work figuring out how they can pay for less and less stuff and keep more and more premium, because that's the business model of an insurance company. Collect premiums, pay as few benefits as possible. That's their profit margin. And then Cigna does not currently cover and has never covered any of these amniotic products. When it comes to your local insurances, if you're in Texas, Texas Health South, if you're in Georgia, WellCare, here in Florida, Freedom, et cetera, those are going to be more of a case-by-case basis. I don't like to generalize on those because those regional insurances are much more specific in their approvals and their declinations.
So let's talk a little bit about what that window of opportunity is with these insurance companies for payment of these therapies.
Sure. So typically, this is being considered for payment by insurances because it lowers risk and it reduces expenditures. Osteoarthritis has been a real sweet spot for us because what happens if they fail conservative care therapy, they fail pain management, their next step is typically a total knee arthroplasty, a knee replacement, a TKA. The average cost of a TKA is about $42,500 if you look at a meta-analysis from hospital data across the country. Per knee, mind you, right? So when we show you some of the reimbursements for these amniotic tissues and you go, wow, that's a lot of money. Well, compared to surgery, it's actually gonna be a lot cheaper. So there's no published LCDs specifically for the use of these products in orthopedic applications right now. There are some LCDs, and with commercial insurances, they're called formularies or drug formularies when it deals with medications and products that say what this can or cannot be used for orthopedically. There are LCDs and formularies that define its use for wound care. Wound care has been an application going back over half a decade now with clear coverage. And then also perioperative, when you're doing a surgical procedure to reduce the surgical wound and to reduce scar tissue. These products have been covered for that for many years as well. But as outpatient basis, it's a developing market. And it essentially goes case by case, just like when you're doing something that doesn't yet have an LCD written. Just because there are no rules doesn't mean there are no rules. It just means they haven't been defined and published yet. So that's why you go through the process of prior authorization on a case-by-case basis to see if it meets the insurance company's guidelines. Now, there are guidelines. They do exist. They're just not published right now. So unfortunately, we're taking the test without really knowing the answers. We have to wait for the insurance company to give those on a case-by-case basis.
So let's talk about the product that is being, or one of the products that are being covered that have been issued a HIC code. Let's talk a little bit about the Palagen.
So there's quite a few products that have been issued HCPCS codes now, and I believe for the most part they're good products. The major factor that we've come into is that certain products will adjudicate more favorably than others. And we found that Palagen and NovaFlow, Flow, and ProMatrix by Amniotic Allograft, and that Q4174 code has been approved in more instances when we've requested prior authorization than when using other products. So right now, that's kind of our go-to product because we're seeing the broadest coverage, approval, and authorization for it. Now, we're constantly evaluating other products. I mean, I just got back in town from another tissue bank I was visiting that may have a new code coming out in July with even broader coverage. So as new products come to market and have more favorable guidelines, we do our best to test those in our own clinics first, make sure they adjudicate properly, and then in a chart review in a post-payment situation, all ends well with no recoupment, and then training our clients how to bring that out as well. But right now, active, this Q4174 seems to be the most favorable code, and that code is for every quarter ml. So you'll see a maximum number of units of 8 that's allowed on a single data service, which is 2 mLs. So we're most commonly going for that 2 ml prior authorization when we're doing a large joint, like a knee or a shoulder with a significant loss of tissue, whether it be meniscal cartilage or otherwise. So these products are minimally manipulated. They do follow FDA's minimal manipulation and homologous use guidelines. And it's processed in a way to preserve these cytokines, growth factors, and that cellular scaffolding. Cellular scaffolding is going to be a term you probably hear a lot tonight. And that's really what these are indicated for. They're indicated to fill loss of tissue or tissue void. They're indicated to help close wounds. They're indicated to help close wounds, whether they're external or whether they're internal. If you've got a cartilage tear, that is a wound. There is a loss of tissue. So a lot of people say, oh, it's only covered for wound care. Well, you can have external bleeding if you cut your finger. You can have internal bleeding if you get in a car accident. It's still bleeding. One's superficial, one is not. So yes, it is covered for wound care. You can have internal wounds and defects. So that's why this can be covered and why this Section 361 product can be used. So the last aspect of candidacy, and I believe the most important, is that this cannot be the first thing you attempt with the patient. The patient has to have documented to try and fail conservative therapy lasting 90 days or longer, and if not contraindicated, consisting of a course of oral NSAIDs. Now, it can be over-the-counter oral NSAIDs like ibuprofen, Advil, or acetaminophen, Tylenol. It doesn't have to be a prescription non-steroidal, but if they're not risk factors that keep a patient from being able to use that, then that has to be documented as part of their medical record. Now, in some things that we do, like hyaluronic acid injections, you can take the patient's word for it. But we have found in these amniotic products, if they say, yeah, I've been ibuprofen 6 to 8 capsules a day for 3 years, you have to get that in a medical records request from their primary care doctor or their previous provider. You basically have to prove that they've been doing it for a long time. You can't just say, oh, the patient told me so. So that's one of the fine points of scrutiny that I found makes a big difference in these approvals or not in your documentation. And then at least one other indication is typically required. They have tried and failed either physical therapy, which can be formal or informal home exercise, compression, bracing, orthotics, or assisted devices, some type of DME. Viscosupplementation therapy is a great tried and failed conservative care. So if you've done injections of hyaluronic acids, or if the patient's had injections of HAs, typically this is a well-indicated next step if those HAs have been ineffective and not provided a complete improvement for that patient. Failure of corticosteroid injections like Kenalog and dexamethasone. Topical analgesics, whether it's over the counter like Bengay or a prescription compound product. Attempting to lose weight. Now, there are certain parts of the country where this is specifically required, like Georgia. You've got to document, if they have well care, you've got to document that the patient tried and failed weight loss. And if they didn't, you have to put them through a course of weight loss. So sometimes this can actually create other revenue opportunities for you, like that example right there. And these ancillaries create a lot of your revenue. And then lastly, home remedies. ice, rest, heat, etc. Any one of those plus a course of NSAIDs lasting 90 days or longer is typically going to meet or exceed the medical necessity requirements to get these cases approved. So let's look at the economic considerations. Now that we've looked at some of the documentation considerations, there's not a published fee schedule for this. You can't go on the physician fee schedule lookup tool on cms.gov and type in Q4174. It'll come back data not available. So it's not going to show you what you get paid in every region of the country, and different regions pay differently. So I've averaged here, taken kind of a broad average on Medicare. It typically pays about $375 per unit, around $3,000 for a 2 ml injection, which is a typical volume. Now that can vary wildly from state to state. If you're in one of the states governed by Navitas as your Medicare Administrative Corporation, they're going to pay a percentage over your invoice, and it's going to be lower than that. There are other states with more favorable payers. If you happen to be in Georgia or the Carolinas and working with Palmetto GBA, or if you're lucky enough to be up in the central portion of the United States with Minnesota and Wisconsin and Illinois with WPS, they tend to pay a little bit more. So Medicare's fee schedule is regional for this and can vary, but a rough estimate is about $3,000 for a 2 ml injection, which is about double your cost of goods. Not bad. Now with your commercial insurers is where it gets really exciting from an economic standpoint. We've seen some cases adjudicate for close to $10,000 on a single 2 ml injection and create $7,000, $8,000 of profit margin. There's other commercial payers that are not as favorable. And that's why they call it a payer mix. It's not unlike how you get reimbursed for your other services. Different carriers reimburse differently. This is an example from Blue Cross Blue Shield. Do you want to go over this one, Lisa?
Well, I was just going to say, this is actually from a claim that we billed out on a client of ours, and we just got this EOB back early this week. And so I thought this would be a really good, this is kind of, you can correct me if I'm wrong, Lance, but this is kind of a middle of the road, I would think, reimbursement. This is Blue Cross Blue Shield of Texas. The provider billed out, 7768 and 6360 was allowed, and this is on one knee. So we had both knees prior auth. And so for both procedures, he got a check of, a little over $10,000 for both from the payer. And then of course you have the patient responsibility on top of that. So yeah, I'll just let you talk about it. But I was excited about this one because we did this one. This came from one of our clients that we did the billing for. So
it's a good example. I'd say it's a very average example, which is great. Kind of a middle of the road example of coverage for this. And this was an osteoarthritic case with secondary pain, loss of function, and gait abnormalities. You can see from the ICD-10 codes there. So again, osteoarthritis tends to be a good one for this. So here's a Medicare example. You're going to notice that these numbers are a lot smaller. Now this was also only 1 ml. It was 4 units of the injectable. 3,000 was billed. Medicare allowed 1,550. So the 20% coinsurance of the patient was $310. The reimbursement from Medicare for the Palingen itself was $1,215.20. So that's about $500 over the cost of goods for this 1 ml injection. If you're doing a 2 ml injection, be roughly twice that. Now you're still going to get paid for your other codes on that data service, office visit if it's applicable. This one had a 2.5 modifier, so the patient had a separately identifiable complaint or a significant amount of patient education and documentation in the chart to support that. They had their large joint injection, the 20610, and they did it under fluoroscopic guidance, the 77002. So the overall reimbursement for this at the provider payment amount was over $1,400. The cost of goods to do this procedure, probably about $900 and change, so about a $500 margin there. And then the patient's coinsurance, $360. Now, if the patient has a secondary, it may pick up that coinsurance. So I do want you to keep in mind on Medicare, we're only looking at primary Medicare here. We're not looking at the secondary adjudication. So let's talk about the product costs real quickly. The most common volume that we see utilized is 2 milliliters, 2 cc's of the Palingen AnovaFlow. The Palingen AnovaFlow is the amniotic fluid only without the micronized placental tissue. And when we're dealing with commercial insurances, this is the primary product we use. The commercial insurances don't take into consideration, well, some are starting to, but for the most part, don't take into consideration what you paid for the product. Their fee schedule is based on the code, not what you paid for it. So if you pay less for the medication, you have more margin. If you pay more for it, you have less margin. The commercial insurances kind of just play a game of averages. With Medicare and TRICARE, especially if you're in a region governed by a MAC like Navitas, that pays a smaller percentage over your invoice product costs, that's where Palingen Flow is most commonly used. And that product includes the micronized placental tissue. And the more you spend on the product, theoretically, technically, that sliding scale, the more you make in revenue as well. So the Palingen Flow is typically reserved for federally funded health plans that pay a percentage over invoice costs. So the documentation and compliance on these cases varies a little bit from payer to payer, but you have to really find these common points that must be charted all the time. The patient has to have a history of present illness where they've undergone at least 90 days of conservative therapy. That always has to be documented. As you're building your chart, I want you to be mindful and think of some hot button terms that may help you get your case approved. One of those terms is to avoid ongoing use of opiates and pain medications. Anything that reduces utilization of pain medication right now with the opioid epidemic that our country is facing is a compliance win. So if you can say the alternative for this patient is a continuation of opioids, whereas this treatment may reduce the need for opioids, that's a check mark in your favor. The other thing is to document what might happen if they don't do this. That could be more risky, more costly, such as surgery. If the failed conservative therapy has not been done by you in your practice, I highly recommend you have the patient do a medical records release and you request those charts from their previous practitioner. It's very important to have the documentation in your hand if it's asked for. One of the questions in the Q&A box so far was from a provider who's operated multiple integrated clinics and they've offered multiple high reimbursement services, including stem cell. What coding, billing, compliances, assurances can you give to make me not worry about doing 6 or 7 figures of billable medicine and later this year having a recoupment, a request for a post-payment liability? This is a big part of it. Making sure that you're building this case strong, you're setting that stage now, and then also the most important point, you cannot deviate from what you put in your letter of medical necessity and what you document in your chart. If you have a big, beautiful letter of medical necessity, all that content better be reflected in your chart. And if you put it in the medical necessity letter, you better have it. If you say the patient tried and failed 90 days of conservative therapy, you better have the documentation to back that up. So that's why the records release from previous providers is, I think, really integral. Or put the patient through conservative care in your office first. That's the biggest thing that we see for folks that have had take-back issues, not necessarily our clients, but in the industry. They didn't properly back up that failed 90 days of conservative therapy. I cannot underscore how important that is, which is why we often use it after a course of viscosupplementation or another in-office treatment, because the conservative care was done under our supervision, and we're not having to worry about having the documentation to support that. That's a big
and I think that's a great point, Lance, because what you know, some of the things that I've seen in the you know, in this process where there may have been a you know, a retrospective recoupment is the documentation was based on what the patient said versus what actually happened medically in a medical setting. So even though, you know, and this is just, this could be just my opinion, but I feel very strongly that if a patient is coming to you and they're saying, yes, I've had, you know, I've been on oral NSAIDs for so long, and there's no medical proof of that. They just say they were, okay, they've been taking Tylenol 3 times a day for the last 3 years. and I've been trying home exercise, even though that technically qualifies, I don't think that's a strong enough case. I think that puts the case at risk for some type of a recoupment. So I think that, you know, taking a step back from that and looking at it from, okay, but what did you do medically? Where are the MRIs? What type of medical therapy did you have that will build that case stronger for you to avoid those recoupments later on down the road, you know? And I, one of the things that I've seen with some of my clients, you know, I've had especially with COVID, you know, I'm just going to be honest, you know, the whole thing with COVID has thrown a lot of clients for a loop, and they're looking to make, you know, they're looking at ways that they can make more income, right? And so they're coming to me and saying, oh yeah, they qualify. And then I look at the documentation and I'm thinking, yeah, by the letter of the law they do, but at the same time, it's not a strong case. You know, it's just like if you go to court, okay, do you have a case that can be appealed and overturned in you know, after the adjudication is done, or do you have an ironclad case that even if you appealed it, it would never be overturned? And I think that this is where I want to spend a bit of time for the rest of this presentation is really identifying and qualifying the type of patient that you're going to want to put this type of effort and it's, you know, and yes, some financial risk into, but you can mitigate that risk by building the case. So Lance, you know, let's talk about that whole part of how do we identify and qualify these patients, you know?
Yeah. And before I do that, I'll give you kind of a brief rule of thumb. If you're doing this procedure on more than 10% of your patient population, you're probably overusing it. This is not going to be your go-to. Every patient that comes in, we're doing this treatment. It's a specialized treatment used in cases that qualify. So I don't want anybody to think this is a get-rich-quick scheme. Now, we have some clients, and I even own some practices, where we're doing really well with this economically, but it's not the primary source of income to our practice. And another word of advice, I'd highly recommend that you don't advertise it. You know, there's a doctor in Chicago that just had some issues. You put up big billboards, stem cell covered by insurance, free consultation, learn more, right? That's not going to end well for him because A, there's no stem cells in it. B, it's not covered by all insurances. You know, that might even be an FTC issue, a Federal Trade Commission issue, not a CMS issue or an AMA issue. So don't be overly aggressive with this. This is not what it is. This is not a panacea cure-all for all your patients that have chronic pain. In fact, pain is not an indication for this. It's not a treatment for pain. This is a treatment for a structural defect. Now, the patient can be having pain as a result of that structural defect. Not saying if pain is one of your ICD-10 codes that it disqualifies them, but pain alone is not enough. They have to have failed that conservative therapy. You have to have the ability to physically prove it. Either you did it personally or you've got it in the medical record. If it's not in the medical record, it doesn't count. And when I say in the medical record, again, I really don't mean the patient self-reporting. I mean actually having documentation that it's been done. Prescription medications in that regard are great because there's a paper trail, right? On the OTCs, if that was recommended by their primary or somebody else, you can get a medical records request, then you're good. If you're ever in doubt of whether or not you've got enough documentation on this, continue conservative care inside your practice until you reach the threshold that you feel comfortable with. Don't overuse this. Maybe it'll help you recover from the revenue loss from COVID-19. Don't try and replace all the revenue you lost with this one thing.
Right.
It won't end well.
Right.
So a really big one here, history of falling and gait instability. Falls, especially in the Medicare age population, 65 plus, leading cause of death, leading cause of expense, leading cause of hospitalization, leading cause of rehospitalization amongst all conditions that someone can suffer from. If you put that in your note that my patient has a history of falling, they have instability, you can do an orthopedic test to show ligament laxity or instability, or you've got imaging that shows loss of joint space, ligament laxity, instability. These are things that I call them the bean counters over insurance that roll numbers are going to look at and say, this is a good one. We should do this. It's less risk, might save us some money. Opioid abuse and dependence, being able to reduce their use of opioids is a good supportive piece of evidence for this to be approved. Alternatives to surgical intervention, very expensive, very risky. And then lastly, and this is pretty important, you've got to let the patient know that they may have coinsurance. And you should execute an ABN, an advanced beneficiary notice, and give your patient your financial policy and let them know if your insurance doesn't cover this, you may be responsible for it. And put that out there, because we showed you that 2,000 and change copay on that Blue Cross Blue Shield case, right? You can't necessarily just fail to collect that and write that off. You have to make a good faith effort to collect the coinsurance from the patient, because if you ever get caught waiving coinsurance willy-nilly, what the insurance companies will do in a retrospective analysis is say, you billed us $100, but you really only expected to get the 80 from us. You never intended to collect that 20 from the patient. So we're going to pay you 80% of $80. We need 16 bucks back now. So you always want to make sure you can document that by mailing at least 3 statements in 3 consecutive months showing that amount due and making a good faith effort to collect it. Never telling the patient you'll accept their insurance's payment in full. Becomes even more important if you're not a network provider, but I'm not going to get into that in balance billing tonight. There's a whole other webinar you can watch on that one. So those are some important factors.
And I think too, you know, when you look at some of these qualifications docs, one of the things that you need to look at is your own internal processes. Does your paperwork, does your consultation paperwork even address some of these issues? Is this a question that you ask patients? You know, I know it can be a sensitive issue to ask patients about prior and current drug use, and patients will lie about it. You know, they don't want to tell you that they had an opioid addiction, but if you can, in a way that's sensitive and caring enough, let them know that, look, you know, in order for us to be able to qualify for you, we need to know, are you at risk? Is there a risk here that we need to know about, that we can document to help your insurance, you know, consider this for payment? And then maybe they'll open up a little bit more. This is actually huge with the VA, because one of the mandates that the federal government has taken and that President Trump has taken is to really expand natural medicine and non-opioid types of treatments for our veterans, because there's been such a crisis of opioid addiction amongst the veterans. And so when you can, you know, take somebody like, especially with a VA case, and you talk about this and you identify this as part of the case on a VA patient, you're going to have a lot higher likelihood of the VA approving this treatment and this therapy, okay? And so, you know, Lance, let's talk about what you would want to do to, you know, you talk about, you know, they need to have had at least 90 days of failed therapy. So let's use a Visco case as an example. How would you document that to help build this case for the allograft injections?
So I'm a huge hyaluronic acid fan. Hyaluronic, one of the original FDA-approved Visco supplements, helped save my knee from surgery decades ago. And it's been something that's been a core focus of our practice and that we help teach our clients for many years since. When we have these cases, the end goal when we've got an osteoarthritic case is delay or avoid the need for surgical intervention. That's typically number one on your to-do list for these cases, right? So then we have to think, when we're setting up our plan of care, let's well define that plan of care to say, if this doesn't work or if this happens, this is the anticipated next step. The best way to get these products approved and to not have a recoupment down the road is to have already said, I plan to use it under these circumstances, and then those circumstances come true. That's one of the best and safest ways, in my opinion, to use a product like this that has very specific documentation requirements. So the following is a direct quote from our plan of care. If the series of hyaluronic acid injections result in improvement of function, reduction of symptoms, but fails to provide complete relief of symptoms and return to normal function, and to avoid the use of opioids or TKA, knee replacement surgery, an injection of amniotic allograft tissue will be utilized to reduce local inflammation, provide cellular scaffolding, and to fill the local tissue void. So almost like when you did a research paper in high school, I hit all the key points there. Fails to provide relief. They have a functional need for this. ADL involvement, they did not return to normal function. Avoid the use of opioids or surgery, reduce risk. Injection of the allograft tissue is being used specifically as a scaffolding to fill the local tissue void. So if you get a post-payment recoupment, and this was in your original plan of care, and now they're now looking at whether or not they want to let you keep that money for that Q4174, your injection Palingen, it'd be really difficult for them to make an argument to take this back when you laid out exactly how and why you plan to use it, and when your subsequent documentation aligned with that. I also want to point out a little known fact. Most of the people who will conduct a post-payment review on your facility get paid a bonus based on recoupment. I have a friend in California. She does contract audits, big hospital groups and surgery centers. She gets a portion of her recovery. When you get a records request and they say, we want to see these 12 charts, okay, that's chum in the water if you're going fishing. They're going to look at those charts and say, how strong are these charts? If your charts are really solid during a random chart audit, they're not going to go past that because they're unlikely to get a commission on recovery from your account. There's over 900,000 physicians that participate with Medicare in the United States. They're going to move on to an easier target. So having good charts is actually your best defense from a post-payment recoupment, because you might not even get to that full-blown audit if you pass that chart review successfully. There's other little tricks like knowing you can request an administrative fee for the preparation of those documents. That's another sign. Uh-oh, this doctor knows their rights under the law. They understand that ERISA gives them certain rights. They're probably going to be more compliant than a doctor that doesn't know they have rights. So those are some things that specifically Lisa's company can help you with. I like to use the term bulletproof you from compliance risk factors. And it might sound like a lot of detail and a lot of work, but honestly, a little bit of work now is going to save you a lot of pain later.
That's exactly right. So, so then, if you have, you're going to need to take some time, all right, to look at your patient base and look at possible patients who might qualify for this therapy. Maybe sit down with your clinical team and look at 10 to 15 charts a week and really take a look and see if you already built a case to begin this process. Maybe not the allograft injections, but maybe you're ready for the visco. But I think that's the first step, is to really sit down and thoughtfully qualify this case. And once you've done that, then the next thing you're going to want to do is schedule the patient for that consult or the exam that will help build that case for medical necessity. So Lance, talk a little bit about some of the bullet points that you would want in that consult.
Dr. Domingo, are you still with us? This is actually one of his live patients.
Oh, cool.
But it'd be great if you could take us through it, sir.
Yeah.
Well, this patient was a 40-year-old male with chronic pain. He's an active runner, just liked to exercise, a lot of squatting, running, and lifting. His KOOS score, his pain scale disability, was at 4.5%, and with relatively normal ADLs, the patient constantly used ibuprofen and ice to stay active. Orthopedic tests for this patient revealed limited and painful range of motion, crepitus, that snap, crackle, pop in your knees. And we did x-rays on this patient and revealed reactive sclerosis, osteophytes, displacement of the patella, and on the scale, on the Kelvin-Lorentz scale of 0 to 4, we graded this patient at 2. So this patient was actually more of a candidate, and we started them on the hyaluronic acid first. We used Genvisc. The patient actually didn't get the improvement they were looking for. So after this, then we, qualified them that they did not get the improvement they're looking for. Still had the effects of osteoarthritis, and we were able to do the Palingen injection.
That's great. Yeah. A question that I get asked a lot, Dr. Domingo, is when you say have tried and failed 90 days of therapy. So for a visco patient, I know that based on the insurance LCDs, a visco case can be repeated once every 6 months. So would you say that a failed therapy would be that they're beginning to experience symptoms, pain, dysfunction, loss of ADLs, loss of function before that 6-month period is up? Is that what you would, that's what we would say, right? So,
Yes.
so then again, looking at the process of this, you know, for my clients, what I would say is you would want the patient to come in maybe for a follow-up visit in 3 months to see how they're doing, right? Or you would want to instruct the patient that if prior to the 6 months, they begin to experience pain, you know, an increase in pain, a loss of function, if they're starting to have to take their NSAIDs again, to come back before that 6 months is up, and there might be an option for a different therapy. What did you say? Is that how you, you know, counsel your patients, or?
Oh, yes. We always have typical protocols where we'll follow up maybe a month, 3 months, and 6 months to follow up and see how the patient's doing. If the improvement hasn't met the qualifications that they're looking for or what we're looking for, then we would consider that a failure and consider doing the allograft tissue.
Okay, awesome. So, you know, I will tell you that as for me, you know, with my clients, and if you're my client and you're asking me to bill these out for you, there's going to be some key pieces of documentation that I'm going to be looking for. First of all, that you have done an evaluation and a consult, and you've begun to build that case. That you have a really kick-butt history of that patient. That you've done a thorough exam, and that you've used a high level of medical decision making to arrive at this decision for this type of treatment. You know, and I've had clients send me their charts asking me to do a pre-cert, and I am going to audit that chart first, okay? I'm not going to, and for those of you who may be on the call, you may have been the recipient of my kickback, and where I look at the chart and I'm going to be like, this is not enough. And I will send it back to you, and I will say, if you can't give me, you know, do you have any prior medical records? Your indication in the history states that the patient saw Dr. So-and-so. Where are those records? I don't see them. And so I'm going to kick that back to you until I get what I feel like I need to be able to do a pre-cert for you that is going to hold up. And that is going to hold up against either a prepayment or a post-payment audit in worst case scenario. What about radiology? You know, are there radiology, and is the radiology fairly recent? You know, patient-initiated assessments are big. So if you can, it's not just what the patient tells you, but if you give them something to fill out, like a COOS, the knee osteoarthritis assessment, or other risk assessment forms that are out there for opioid risk or behavioral. I mean, sometimes you can even talk to the mental status of the patient. You know, this patient has been dealing with these problems, with these knee problems, you know, even if they're younger. For example, like Dr. Domingo's patient, who's an athlete, if they can't do what they do, you know, it's going to affect them. They may be suffering from depression as a result of that. And so these are some things that you can add to your case that really shores it up, you know, and helps us, you know, give you the ability to be able to bill for this procedure and have the peace of mind that this isn't going to all, you know, blow up in your face or be taken back at some point, okay? Also, Lance mentioned the ABN. Always, always get an ABN. And I'm not just talking about for Medicare, I'm talking about for your commercial payers as well. There are commercial ABNs that can be used. Some payers will actually have their own ABN forms, like Blue Cross of Arizona has a commercial ABN form for Blue Cross of Arizona. And if you're in network with Blue Cross of Arizona and you don't use their ABN, it's invalid. So you have to know if that ABN form that you're giving the patient is going to actually hold up, to where if for some reason the insurance doesn't pay you can then collect that money, at least for the product, from the patient. All of these items are going to be used to create that letter of medical necessity, which essentially is a cover letter for your entire case and for your entire chart. So this is just some examples. And again, I have these available for all of my clients on request. Some of these outcome scores are available online as PDF documents. This one is the COOS, so this is just the first few questions, but these are some of the types of things that a patient would fill out. It takes them maybe 5 or 10 minutes to fill this out, but it really helps your case when, in the patient's own words, they're putting it down in writing. It's not just what you're hearing from them verbally, but you've got it in writing, and so you've got something to back up what the patient is telling you. Another one is that I use in other medical applications, but I've actually started recommending this for my clients with the allograft injections, is if you are doing a consultation on a patient, and in that consultation they indicate that they do have a past history of opioid dependence, I would have them fill out this opioid risk tool. And again, this is just a, you know, basically if they can say, yes, I have a history, family history of substance abuse, alcohol, females, and these are going to be how they're going to be scored. A score of 3 or lower, you know, if they basically don't say that I have a problem with any of this, it's going to be 3 or lower. A score of 4 to 7 indicates a moderate risk of opioid abuse, and a score of 8 or higher indicates a high risk. Well, now you've got something to back up the statement of, to avoid opioid addiction in this patient, we have this risk assessment that the patient did because of their prior history of opioid dependence. So again, as we're building the case, we're wanting to pretty much document the insurance company to death, essentially, and give them so much information that, and so much reason for them not to look too deeply into these charts and into the cases, because they just see that we have done the due diligence to present a case that is going to hold up as medically necessity. And here's another one. This is a common one. It's actually used very commonly in hospital settings, but it can be, it's called the Morse-Fall scale. For if you have the elderly patients, your Medicare patients, and again, remember with Medicare, we can't pre-cert, okay? So you're going to basically, what we're going to be doing is we're going to be filing this claim concurrently with the notes and with the documentation. And so Medicare will do a prepayment audit, but what you're going to want to do is really build a good case. And part of that for your elderly patients is going to be their risk of falling. And so if you can have them fill out a fall scale, a Morse-Fall scale, that's going to be another piece of documentation that's going to show Medicare that you've done your due diligence in building this case. Other things that you're going to want to show in your documentation is either a radiology report that shows the defect or the anomaly in the knee or in the joint that you're going to be doing the injection on, or a visual tracing of that problem. And this clearly shows, you know, how you're basically bone on this particular knee. You know, you can see on the right knee, you know, a nice space between those two joints. On the left knee, complete degradation. So this is going to be a big, you know, picture for the insurance company to see when we're submitting that letter of medical necessity. And so what we're going to want to do is, the third step is, after you've qualified the patient and after you've done your initial consult and you're starting to build the case, then we're going to do the eligibility and the pre-cert. So you would send that eligibility to us, the request for the eligibility for this code. And, you know, the insurance company may say that it's covered, but that doesn't mean it's covered, okay? It could be covered for wound care, but we're going to have to make sure that it's covered for the orthopedic application, okay? Which means the pre-cert is always going to be necessary. Every single time we bill for this, you're going to want to pre-cert if possible. And so if benefits are available, we're also going to want to check for the deductible amounts, accumulations, co-insurance amounts, gather up all of our documentation, and then complete that letter of medical necessity. You'll then submit that chart to us so we can submit it for the pre-cert. And while you're doing that, you'll want to inform the patient of their financial responsibility and have them sign an ABN. Now, the government payers, as Lance has said, they don't do pre-certs. So what they'll do is a prepayment audit. And there are ways where we can submit a claim electronically and then concurrently submit the documentation along with the claim by having a document control number on that claim and then using the same document control number to upload in through the Medicare portals. So we're going to do that. We're going to submit those claims concurrently, but there's a risk that Medicare may just say no. All right. And if they do, then what you're going to have to do is you're going to have to get that ABN from the patient. So this is a sample of the verification form that if our clients want the verification done and the pre-cert done, we will go ahead and take care of that for you. Lance, why don't you talk a little bit about, you and I are working together now on some of this, and part of the process of purchasing the product from you is the pre-cert, isn't that right? And
It is.
yeah, so talk a little bit about that.
So we cover the cost of the pre-certification. It's built into the cost of the product. It's not something you're gonna have to bear on your own. We pay for a third-party vendor to do this. Lisa and Gold Star Medical is our go-to. I think they do the most thorough job in going through this record and ensuring it's a safe and compliant case. And we do this for a couple of reasons. One of the primary reasons is that we tend to have a long-term relationship with our clients. Usually we've sold them radiology equipment. We've provided clinical training to them. They purchase medical supplies from us that we manufacture or unloading knee brace. So we're not like a sales rep that comes into your office and says, hi, how you doing? Has a transaction, you get paid a commission, disappears. And because we have an ongoing relationship with our clients, we want to do things that protect them and support them, not things that put them at risk. So I don't want anybody out there using this product. If you've ever heard anyone ever tell you, well, insurance paid for it, so that must be okay. That's not necessarily the case, especially with the federal payers that'll pay now, ask questions later sometimes. You have to make sure that you're using it the right way. Payment itself is not confirmation or verification that it was allowed. And I oftentimes say in healthcare, it's not what you make, it's what you get to keep. That is most important. You've all heard these horror stories about takebacks for people that have overutilized or underdocumented or overbilled or even underbilled. That's another thing. Fraudulent billing isn't just overbilling, it's also underbilling. I had a client, and thank God we caught it and helped him fix it. He was giving out 2 different types of knee braces for people with OA. And I said, well, why do you use that knee brace? He goes, well, it's less expensive. It's a lower code. So that's so that I don't get red flagged and get audited more frequently. No such thing as red flags and white lists. They don't exist. There's complex computer algorithms that are scrubbing all this data. It's why the government gave you a check to move to EHR years ago. It wasn't to save trees. It was to make it easy. Well, maybe it was to save trees, but the primary reason was to get doctors to basically raise their own hands and say, I'm a good target, so that they knew where to put their human resources. If COVID taught you nothing, it taught you that Medicare doesn't have enough employees. When you had to go get a pre-cert or have an interaction with them, there just weren't enough people there to handle the load of it, right? So they have limited human resources. They use technology to target those resources. So you want to make sure you've got somebody there from a compliance and documentation perspective, second set of eyes. If you've ever had a patient with a case that was complex and difficult, sometimes you've spoken to another provider to get a perspective on it and get a clinical consult. And sometimes they see something you didn't, recommend something you didn't think of. That's the main purpose of Gold Star Medical Billing and Leases Company. They're going to look at this documentation from a different perspective and maybe help you catch something that you were missing or that you need to add before you go do the procedure. Once you do the procedure, yeah, you can amend a chart and do an attestation it's much more difficult to go back and fix it than it is to do it right in the first place.
Mhm.
So we believe that requesting the authorization, even if, again, it's not required by that particular payer policy, I think it's integral. And I'd rather pay for it to ensure our customers are safe than have them risk not doing it or trying to do it on their own. Because honestly, it took a long time and variance to get these eligibility request forms to a point where we knew the right questions to ask and we knew the right things to document. And in certain places like Illinois, where Blue Cross Blue Shield is becoming more restrictive, we've even created a script that we have the patient call into their insurance and follow, so that not only did we verify it and document, but also the patient did. And the reason that's sometimes important, and I don't want to get too much into the legalities of federal law, but ERISA, the Employment, Retirement, Investment, and Securities Act, it shows that the employer-sponsored health plan, that contract is between the insurer, the employer, and the patient, not you. You accept assignment of benefits. You get paid as a third party. You have no contractual rights. The contractual rights belong to the patient. So those patients can assign you those rights and payment, but you don't have the full protections. If an insurance company tells a patient who they have the legal contracting relationship with, this will be covered, this is your co-insurance or lack thereof, they can't change that determination because that's their contracted individual under federal law. So if you're really paranoid and micro detail oriented like I am, that's actually another layer of protection you can do. You have the prior authorization from Gold Star where they've looked at your documentation. You've got your chart backed up. You've got your patient's recording or attestation that they were approved for it as well. They got you the name of who they spoke with, time, control number for the conversation. These are some things you can do. When I use the term bulletproof, a lot of people throw that around, but if you do all these things, you can actually create armor that protects you from having recoupments.
Mm-hmm. Yeah, that's great. Great explanation. This is a letter, a recruitment letter for medical necessity, and this is a good cover letter that can be used to put at the top of a chart that basically gives in a nutshell what it is you're trying to do. But I always recommend, like I said, I am not the lazy kind. If my doctor sends me just this and says, I want you to do a pre-cert, I'm going to say, where's the chart? Because I'm going to want to send the chart with this letter of medical necessity. This is almost like the facts cover sheet. Okay. Even though it gives everything that the payer might need to make that determination, I want to know, and I want to be able to, if I'm ever called on to fight this claim for you, I want to be able to say, wait a second, we didn't just submit this letter of medical necessity, we submitted the entire chart, and you approved it based on the contents of that entire chart. And we have performed the procedure based on what we said we were going to do in that entire chart. So you can't take that back. Okay. I have a fight there. Now, just a letter of medical necessity without the chart, the insurance company can say, well, you said that you did all these things, but the chart doesn't substantiate it. Okay. Or whatever, but they really have no argument when the whole chart goes with that letter of medical necessity. I also have a narrative format of the letter of medical necessity that, having worked on the chiropractic side of things for so many years and having worked on the medical side for so many years, I have found that insurance companies love narratives. Okay. They hate checkoff forms. Okay, it's just like the old travel cards. They hate travel cards. They love everything in a narrative form. So we have the one-page kind of checkoff system that would go along with the chart, or you could take this letter of medical necessity narrative, build it into your EMR template, and use it as a fillable document. It's got most of the wording in it. You just add the information directly from your patient chart and then support it with the patient chart. And this one is pretty bulletproof. Okay, so this is just another version of an excerpt of a sample of letter of medical necessity. I have all these documents available on request, both the verifications, both types of letters of medical necessity. This is an example of what your ABN form would look like for these Palingen injections. Now remember that an ABN form is only valid for Medicare Part B. Medicare Advantage, you're going to have to check with the payer for their own local ABN. Actually, Medicare states that this ABN form used on a Medicare Advantage patient is invalid. It voids the ABN if you use this on a Medicare Advantage patient. So don't ever use this ABN on anything except Medicare Part B patients. And so essentially, I have this available for you in a Word document so you can customize this. At the top where it says notifier, you can put your clinic information on there, and you can put your fees in there and so on and so forth. So this is what the ABN would look like for the Medicare Part B. And this is an example of a commercial payer ABN, or one that would be, you could use if, for example, the payer doesn't have their own version of an ABN. So the first thing you would want to do with a payer other than Medicare would be to go to the payer site, go to the provider section, go to forms, and then look for notice of non-coverage, advanced beneficiary notice. Do a search in their forms to see if they have a form like an ABN. If they do, you would want to use that form for that payer. If they don't, something like this would work very well. This is actually this is the one I poached from Blue Cross of Arizona. So this is their form that I've actually just genericized a little bit so that you can put your clinic information up at the top of it. And essentially it gives also, one of the things that we do with these commercial ABNs, and I'm not even going to try the drawing tools because I'm new at Zoom, but we put the verification in under the additional information. So we'll put a little narrative that says, here's the reference number, here's who we spoke with. They stated that the deductible of $2,000 has not been met. After deductible, payer may cover 80% of the allowable amount. Estimated out-of-pocket cost to patient is approximately $28.80 if procedure is approved. If not approved or retrospectively denied, patient is responsible for entire balance of claim. Patient agrees to a deposit in the amount of blah, blah, whatever you decide to have the patient pay in a deposit for this procedure. So the patient can see that this is $6,400 procedure that they would, if it's approved, they would be responsible for $28.80. If it's not approved, they would be responsible for $6,400. And then the patient gets to make an election at the bottom of this form. Yes, I don't care how much it costs. I'll go ahead and pay for it. Let's bill insurance, see what they say. Or I'll just pay cash. We don't even have to bother filing this to the insurance, or I don't want the service. So it's the same election that you have on a Medicare ABN. It just looks a little bit different. So always get an ABN form for these non-covered or services that are experimental. The other thing that I do want to point out to you is, and this is a compliance issue, if you finance more than $500 over more than 4 payments, you are subject to Truth in Lending Act law. And what that means is that you have to make a disclosure to the patient in writing as to what you are financing. And again, this isn't if you're offering outside financing like Care Credit, but if you tell the patient, well, we'll break up your payment into 6 monthly payments in the amount of $1,000 each, or whatever you decide. If you're extending credit, which is more than 25 times per year, and the credit is either subject to a finance charge or payable to a written agreement in more than 4 installments, then you have to do what's called a truth in lending statement, or essentially it's just a written case estimate, which would say, here's what the cost of the procedure is, here's what your estimated insurance is going to pay, here's your estimated out-of-pocket, and here's how we're going to collect for that, okay, in these types of installments. But you want to have that in writing for the patient. So make sure that you do a truth in lending statement. So once we've gone through all of this, you know, to get to that point where the procedure is approved, then at that point, you're going to coordinate and perform the procedure. So Lance, I don't know if you're still here, but if you are, how soon, so once the procedure is approved, then what's the next step for them to order the product and get it to them and so on and so forth?
Typically, yes. I do like to see everybody get the product approved first, because first and foremost, you don't know what volume you're going to need until you get that prior authorization. For large joints and medium joints, we do typically see the full 8 units, 2 mLs approved. And you also want to do that on separate dates of service. If you exceed 8 units or 2 mLs, it goes past the allowable limits based on the unit or quantity. So if you're doing a bilateral knee, a bilateral shoulder, you'll want to do one first and the other later. You'll want to put those expected dates of service on your prior authorization request, and then typically order your product accordingly, because this is cryogenically preserved product. It's going to be shipped on dry ice. It'll stay frozen for 3 days inside the cooler that it is shipped in once it arrives. Anything beyond that, you're going to have to add more dry ice or put it in your own cryo storage, whether it's a liquid nitrogen tank or an electrical powered cryo freezer. So I'm not a big fan of stocking a ton of the product. Kind of like to order the product as I use it. That also ensures that it's always from different lots. It's always been freshly tested. You don't have to worry about recalls, which with the tissue bank we've been working with, we've never had a recall. But they do happen in the industry. So I try not to keep a ton of it on hand. So you're usually ordering the product as you need it. Now, the only caveat to that would be if you're really doing a lot of these procedures. If you're a larger group, multiple providers, you're doing 3, 4, 5 of these a week, because it's shipped with dry ice, it's $150 to have it shipped to you in the cooler. It's $150 if you're shipping 1 ml or 100 mLs. It all goes in the same cooler. So if you're doing a lot of these procedures, you're doing a short period of time, you can order more product to save on shipping, but I still like to kind of order almost on a one-off per procedure basis. So your overall plan is going to be identify patients that might be candidates. They're not responding well to conservative care. It's a case that's not being well managed. That's not maintained within normal limits. We're going to evaluate them for this, see if they've got the findings both objectively and subjectively, as well as the failed conservative therapy to be a candidate. We're going to fill out that LMN, and we're going to submit that along with an eligibility request form to Gold Star Medical Billing. They're going to review it, and they're going to say, this looks good, and we're going to go get the prior authorization for you. Or they're going to send, hey, this doesn't look good. Before we get the prior authorization, you should fix these things. And then we'll run your prior auth. They're going to run the prior auth. They're going to let you know if it's approved or denied. And you're not going to pay for that. They're going to bill us for it. So that's not going to be an out-of-pocket cost for you if you're purchasing the product from us once it's been approved. If you're going to submit a couple dozen and maybe they all get denied, we're still picking that up. That's the risk that we're taking to help make sure that our clients are using this in a compliant fashion. The pre-certifications, you know, they can be turned around on the same day, but they can also take a lot longer than that, especially with the prior authorization. So I like to tell my patients, I say 7 to 10 days. Actually, I tell my patients, and usually they get done well within inside of that. At least to give you some low expectations here, but I've seen their work. It's really good and very fast. So they might outperform what's on screen.
And you know, part of that is, you know, especially like with my clients, a lot of my clients are very new to this. And so I'm anticipating that I'm going to be kicking some of these back before I even submit them for the pre-cert. And so, you know, I don't want the clients jumping the gun and saying, all right, we're going to schedule you in 7 days. They send me the pre-cert. I look at it. I'm like, you need to do more with your documentation and then get it back to me. And now another 2 or 3 days is transpired, you know? So that's why I say 10 business days, you know, like you say, I'm on the more conservative side, but I feel like once my clients really start getting the hang of it, then it's going to go very, very smoothly and it'll move along very quickly, you know, because we've got on our end, we've got the process. We know, you know, we've got the steps. Once we get those charts from the provider, we know what to do. It's just the providers are going to have to learn how to really make sure that they're charting those cases correctly before I feel comfortable submitting it for pre-cert, at least with my clients. So. So, you know, Lance, talk a little bit about what you're seeing in this chart review here. You know, this is basically it's kind of a exam and injection all in one visit. So this is basically what that note would look like after the pre-cert has been done, and this is the day of the procedure.
Mm-hmm. So this is your SOAP note, your standard SOAP note, and you've got your subjective and your objective on this first page. So the subjective is that the patient has knee pain with secondary considerations, including joint tendon or knee OA confirmed by imaging. The patient has not been well controlled despite a trial of NSAIDs and physical therapy. Pain intensifies with activity. Risks and benefits have been discussed, and informed consent was collected. The patient presents today for their intra-articular injection of Palingen in the left knee, and they return for follow-up on the knee after viscosupplementation has been completed. The patient has crepitation that's been documented. They've got a decrease in pain when walking up steps as opposed to down steps. They deny constitutional symptoms. No localized rash or other contraindications have been identified. Then we get into the objective. We're looking at the tenderness to palpation. There's medial joint space loss in this particular patient. There's no effusion. Now, not that inflammation is a contraindication for amniotic injection. It's not, but it's generally a good idea if your patient does have a joint effusion to perform arthrocentesis, drain it, consider utilizing a corticosteroid, and then doing your therapeutic injections at a later date of service. There are certain procedures like hyaluronic acid where you have to do that. With amniotic fluid, because it's anti-inflammatory, you could technically do it on the same day of service, but I tend to advise our clients it's better if you're going to do an arthrocentesis to separate that from the therapeutic injectable. Now we're looking at the orthopedic tests that have been done here, Apley's, McMurray's, anterior posterior drawer test, etc., documenting that. And the procedure, after we've got written consent, we flexed the knee to 90-degree angles, skin was prepped with iodine, chlorhexidine, whatever you use, what gadal and length needle we were using to inject into the knee, the 1 ml or 2 ml of Palingen. Post-procedure, they were given their instructions. There was no swelling, inflammation, or adverse events visible during or after the procedure, and the patient tolerated the procedure well.
So just to reiterate, you know, when you're looking at the objective and you see these tests that were done, the exam on the knee, this is not just a reiteration of the exam that was done at the original consult. You are re-examining the knee that day, correct?
Yes.
Okay. Because sometimes what I've seen in the chart reviews is that there's been a little bit of, you know, salting, you know what that means, same as last time. And it just seems like they took a prior knee exam and copied and pasted it over to the new day. Which,
that is called a canned note. And if you do that, all your E&Ms will get yoked from you in a post-payment review.
Exactly.
So Medicare did us a favor for the first time in a long time. They adjusted the documentation requirements for evaluation and management visits, and they reduced them. But now more than ever, that canning is kind of important because, hey, we've taken the threshold down. Now we really expect you to actually do this on a case-by-case basis. And
Exactly
you might have
right.
noticed on some of the EOBs we showed you earlier that there were E&Ms on the same date of service as the procedure with a 2.5 modifier. So it was separately identifiable. You had a secondary complaint, we had 10 minutes or more patient education, and we basically built up the documentation that supported that E&M. You're not going to automatically attach an E&M to every one of these procedures. If you don't do these exams, don't copy and paste it. Just don't bill for the E&M on that date of service. That's much, much, much safer approach. E&Ms don't pay much anyway. If you're doing a level 2, it's what, $45 or so on average?
Yeah.
Not worth risking.
No. All right. And so the last part.
So the assessments you're coding, these would be your ICD-10 codes for what the primary and secondary diagnoses were, as well as your CPT or HCPCS codes for any products utilized. And then your plan is what happens next. We're going to continue the previously written plan of care. We did the left injection of Palingen today. Post-procedure review with the patient. We're going to follow up as scheduled. Our next visit's a right knee Palingen. So we're going to put that forth. And if your plan in your SOAP note matches what you wrote in your original examination, that's a really good factor for compliance because you can show consistency. You definitely want to have consistency within a patient's chart. You don't want to change really rapidly without explanation why if your plan of care changes halfway through. Now, if you're doing a follow-up outcome study with the patient, you're repeating the KOOS, or you're doing a WOMAC, or it's a shoulder, you're doing a DASH, and they're not progressing, and maybe they're getting worse, that's a good reason to change your plan of care. Otherwise, the whole point of the plan of care is we expect this to happen. And as long as it keeps happening, we're going to keep doing it. That's protection. That's part of that suit of armor from a compliance perspective. Oh, and by the way, if you said my plan is if this happens, we do this, and you don't do that, that's even worse than not saying what you're going to do.
Yeah.
So you got to make sure you actually follow your plan once you've written it.
Mm-hmm. Absolutely. Absolutely. So the last step of all of this is going to be to file the claim. And that's where you're, if you're listening to this and you're not a client of ours, a billing client, your office is going to have to file the claim. It is my recommendation, again, when you file the claim, that you include the op note for the day of the procedure, plus send the prior records. Again, it doesn't hurt to do that. And if you did get a pre-cert and you got an auth number, make sure that auth number is on the claim. A lot of clearinghouses now have the ability for you to upload your medical record attachments with your electronic claims. If not, then you can submit the claim electronically with a document control number in box 19, and then upload the records through the payer portal like Availity or through Novitas or Noridian. These provider portals have ways for you to upload these documents. Under the commercial payers, just depending on the commercial payer, we actually have dropped some of these because we're sending the entire chart again to keep it all together, where we're working with a software program that's not very sophisticated, or we're working with a very basic clearinghouse. We've actually dropped them to paper and then just sent the whole thing in by paper, put postal tracking on it, and we've had great success getting those paid if the payer accepts paper claims. Now, there are a lot of payers now that don't, they don't accept paper claims anymore. But if they do, that is something that you could consider doing. Not necessarily recommended every single time. If you've got ways to submit your electronic claims and attach the chart with the claim, that's the best way. Okay, but other than that, there are ways that you can file. And if you need help with that, and let's say you're not a billing client of ours, we can help you with some training on that. And help show you how to access these portals if you're not used to doing that. So, we're as a company, we're not just a billing company. We also do training and staff development with your office. So, you may have a very capable staff who can do this for you, but just make sure that, that you're doing it right. So that kind of concludes this. So, I know we've gone a little bit over time, about 10 minutes over what I anticipated. But we did get, when I put this out to my clients and I let them know that we were having this, they were super excited about it. And a lot of them wrote in with some questions. Okay. Lance, did you check the Q&A to see if there were any other questions that came in?
I've been typing and answering some of the little ones that weren't too difficult, and the big guys I repeated and answered on screen.
Okay, perfect. So I took 4 of the main questions that I got kind of over and over again, and I put them in as common questions and concerns, and maybe the 3 of us can kind of talk a little bit about some of these. So the first one, and I know we've addressed this, is we've heard that even if you get the pre-cert, the insurance company will audit the claim and recoup the money. I hear this a lot. So why do you think we're hearing this? What do you think the main reason is why we're hearing this? Because honestly, from your perspective and from my perspective, this isn't what we're seeing with us, with the way we do it with our clients. But is there a reason why we're seeing some providers experiencing this? What do you think?
Well, I don't know if you've ever noticed or heard that analogy that a dissatisfied customer will tell 100 people, but a satisfied customer might tell one or two, right?
Yeah.
So the people that have the horror stories that have done it wrong and been pinched, they tell everybody, right? So there's a lot of misconceptions about risk assessment when you're getting into certain areas of medicine. I've seen this actually happen a lot in DME too. I've talked to doctors about having a DME license, filing an 55S, and being able to dispense and fill DME prescriptions inside their practice. They go, I heard that that's the fastest way to wind up in jail. That's the fastest way to have millions of dollars of recoupments. Well, no, a DME audit's one of the easiest you'll ever go through. They're looking for a letter of medical necessity, and that you actually gave the piece of DME to the patient that was prescribed and billed for. You know, I might be, maybe there's a little more to it than that, but generally speaking, that's a typical DME audit, right? And there's exemptions from DME accreditation for clinics that are owned by exempt individuals, physicians, MDs, DOs, NPs, PAs, PTs, and other professionals. So I find a lot of this fear is sometimes misinformation, but more often than not, just lack of education. And I'm not blaming anybody for not knowing all these things, okay? I read LCDs and I'm on the RSS feeds for the updates with CMS and payers. I actually enjoy that stuff. I'm that sick, weird person that likes word puzzles. So I read this stuff. It's on my nightstand. You know, my wife might have to
He's the data geek.
yeah, I like it. It's interesting. For me, it's a brain teaser, but with words. So I stay up to date on this stuff. I still learn things that I miss. It's constantly changing. You know, Medicare changed pricing of drugs every 90 days in the Red Book. LCDs can change within a calendar year, sometimes even 3 or 4 times. So it's more than a full-time job to stay up to speed on this. So I find that most of the fear with these recoupments and takebacks is just lack of experience, lack of education, and then maybe some of those horror stories getting trumped up. And then there are kind of like a self-assessment you can do for risk. Like I said, if you're doing this with more than 10% of your patient population, probably overusing it and being aggressive with it. If you can't sit across from the table and explain to the auditor why you did what you did, you shouldn't be doing it. So look yourself in the mirror when you have the chart and say, if I was reviewing this chart, would I accept it? And be honest with yourself. If you can't answer that question, yes, don't do it. The best way to be conservative and be safe and to avoid a recoupment is accept the right patients, do the right treatments. And I know that might sound simplistic or even preachy, but it's true. You know, I had a competitor of mine who was billing the arthrogram, the contrast dye study, on every single injection of medication. And they go, oh, well, insurance pays for it. That'd be like taking an x-ray every time you adjust a patient if you're a chiropractor, every time you clean their teeth if you're a dentist. It's clear overutilization. Just because it's getting paid for doesn't mean it's okay. And I think that's why people are afraid with the pre-certs, but it's also how you did the pre-cert and what you got. Did you write down the name of the representative? Do you have a control number? Did you do it in writing? You know, some of these can be done in written. We recently just added having the patient do the request and documenting that as well as an even further layer of protection. So if you are really committed to compliance and you say the most important thing to me is to do this right and to make good money fairly and not to be overly aggressive, I wouldn't really be worried about recoupments because security systems keep honest people honest. Chart reviews and post-payment reviews are meant to give you a little bit of a, well, you better not do the wrong thing because there's a penalty. But if you're honestly operating, you shouldn't live in fear of a potential recoupment.
Yeah, that's awesome. What if I don't have fluoroscopy? We use ultrasound guidance. Will that have an impact on authorization or payment?
Not for the procedure itself. Now, if you're using an ultrasound examination to document loss of tissue, or if you're using an arthrogram with contrast dye in a fluoroscopy setting to document a diagnostic finding, then yeah, diagnostic findings with those devices will increase the strength of your chart. But if you use X-ray, MRI, or physical examination to establish your medical necessity, this procedure does not require guidance to be covered. You can bill it with a large joint injection or other application, and it will be successfully adjudicated. In fact, to use fluoroscopy and ultrasound, you actually have to have more documentation and reasoning for why guidance is necessary. For example, if you've got loss of joint space and osteophyte formation, well, needle approach might be impacted by those abnormal findings. That's why we have to use guidance. So it's actually the opposite. It's easier to do this without guidance, but guidance can strengthen overall your note if you're using it in a diagnostic application.
The next question was, maybe Dr. Domingo could help us with this one. How long after viscotherapy or physical therapy is completed should I evaluate the patient to see whether it has failed or not?
Well, as we mentioned earlier, I do the KOOS score, do keep track of our pain scales. We'll do it on the initial visit. We'll do on a discharge, and depending if they're looking for more improvement, 1 month and 3 month follow-ups, we'll do the KOOS score again, evaluate the patient, do our orthopedic tests. So the soonest I usually do these injections is probably a month after visco supplementation, just to give it a chance to have its effects.
Mm-hmm. Okay, here's another one. If I'm out of network with the insurance company, does it affect whether I will get the pre-cert?
Well, I think that's a good one for you, Lisa.
Well, you know, the thing is that right now, most of the clients that we have been doing the billing for we're not doing a lot of out-of-network pre-certs, and so we've done a few, and they one was accepted, one was not. The others that we've done were for in-network, so we really don't have a lot of experience with that, but I do know that there are a lot of providers out there who are out of network with insurance companies, and so I didn't know if you might have had any insight into that, seeing, you know, what's coming back on the pre-certs. Do you have any?
It's heavily regionally specific. So like, let's take New York State, especially in the major metropolitan boroughs there. Most providers are still out of network. We've seen out of network authorizations approved for that with Blue Cross Blue Shield, Aetna, and other carriers. But that's a lot different than, let's take Alabama, for example. If you're out of network with Blue Cross Blue Shield there, you're out of luck with Blue Cross Blue Shield there. Yeah. So the out of network question is really regional. And I find certain states tend to be more favorable areas to practice out of network. And honestly, it's areas of a lot of large employers with captively funded health plans, higher income areas. That tends to be where out of network benefits are going to be more accessible, more prevalent, and are going to have a wider range of acceptance and authorizations. I hate to give a general answer like that, but it's very, very geographically variable.
Yeah. Well, and I get the, you know, and the funny thing is I get that question a lot. I'm asked, you know, well, should I be in network or should I be out of network? And my answer is that it's a business decision. You know, it's a decision based on your geographic area. It's a decision based on sometimes whether you can even get in network or not, you know. But I think that it probably, I don't think it should hold you back or hold any clients back from trying to get the pre-cert. You know, it's not going to hurt on the commercial side to attempt to get a pre-cert if you're out of network. Now, whether you're going to have as much luck out of network getting the pre-cert, especially if the payer is looking at this patient, and of course they have the contract with the patient, so they're wanting to protect that patient, and if that patient gets the same injection done in network versus out of network and what their out-of-pocket costs are going to be, a payer may look at that. You know, they may or they may not, again, just kind of depending on the geographic location and the favorability of out of network. California is kind of the same as New York. You know, the panels have been closed for so long. There are so many doctors that are out of network, and the benefits really aren't that bad out of network in California and New York and some of these other areas. But I'm kind of glad that you said what you said, because it sort of confirms some of my feelings about it. So I'm glad that we're all on the right track. Okay, well, we're going to wrap this up, and I know this was a long presentation, but I think this is one that is going to be extremely beneficial for all of our clients to maybe go back and re-watch and revisit a few times to really get their head wrapped around this whole process of this type of therapy. And I can't thank you guys enough for being on the call. and taking the time. For more information on the Palingen and the other regenerative medicine products, you can call Lance. Their number is 855-854-6332. And then they have an email. It's orders@integrativepracticesolutions.com. If you have any questions about billing, pre-certs, documentation, compliance questions, and you're listening and you're not one of my clients, please feel free to give us a call. My number is 866-942-5655, and we offer a complimentary 30-minute consultation to talk to you about your practice and your situation and whether this would be a good fit for you or not. So do you guys have any final comments that you'd like to make?
I'm good. I feel like we just taught like a college course, Introduction
I know.
Amniotic Allografts 101. I'm really pleased with the information we laid down, and I hope that those of you attending learned something new from this, maybe cleared up some misconceptions. And if as you're reviewing this and going through your mind, you come up with any new questions or concerns, please feel free to reach out to us or to Lisa. We're more than happy to answer questions and find good ideological fits for business partners that we can really help get the most out of our experience and resources.
Yeah, and by the way, I do have the handouts available for this, so you can email me info@goldstarmedical.net. I'll be happy to send you the handouts with the slides. Okay. All right, everybody. Well, thank you so much. I know it's late, especially on the East Coast. You're all probably ready for bed or DVR or whatever, and or dinner. And you guys have been awesome. Thank you so much. And
Thanks, everyone.
we'll talk to you again soon. Take
Have a
care.
good evening.